You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia. Hello, everyone, and welcome back to the second part of the Gender Affirming Care Series. In this part, we're continuing our conversation with our three special guests, Dr. Thompson, Lucas, and Ray. In this episode, we delve a little deeper into what are the components of transitioning and what it means for different people. From the get-go, I want to emphasize that transitioning is unique to each person in terms of what they want and when they want it. There are many ways that a person can choose to transition, and there's no quote-unquote right way to be trans. I'll go over the basics of hormone therapy for transitioning. And I created this section based on some of the things that I have read and also doing an elective in a gender-affirming care clinic. There are two main hormones that we use in gender-affirming care: testosterone, which is used for masculinizing, and estrogen, used for feminizing. Before hormone initiation, there are a few things to consider. First, a person must be diagnosed with gender dysphoria, or more recently, gender incongruence. This shift from dysphoria to incongruence is actually a more recent change, because we can now prescribe hormones before the person meets criteria for dysphoria, which normally denotes a more deteriorated mental health state or a bigger impact on their quality of life. To be able to diagnose gender incongruence, we need a detailed gender history with goals for treatment. This means gauging the patient's understanding of the desired changes and how hormones would help that process. It's also important to assess the individual's psychosocial, mental, and physical safety, and also their preparedness for the possible risks and side effects of hormones. This includes fertility preservation and family planning. After taking your history, a thorough physical exam with particular attention to weight, blood pressure, heart rate, and a cardiorespiratory exam is needed. It's also recommended, if your patient is an adolescent, to record their height as well. We also normally do a basic set of blood work like a CBC, AST and ALT, lights and creatinine, fasting glucose, lipid profile, and a baseline testosterone and estrogen. There might be also other investigations that you need to consider based on the individual patient's baseline risk profile or medical history. Let's delve into how we actually assess the patient's understanding. Usually we start by asking them what they know about how hormones can change bodies and what they understand of the risk of hormones. TransCare BC has two fantastic consent forms that review the potential desired effects and their expected timelines, plus the potential risks associated with each hormone. I'll link the forms below, and I want to mention that while there is a signature box on the forms, you don't need that form signed to start hormones as long as there is clear documentation of reviewing the effects and risks of hormones with each patient. Getting into the hormones themselves, for masculinizing, we use testosterone, which comes in an injection, patch, and a gel form. The injection comes in two concentrations and it is cheaper compared to the gel. So the pros of it are that, one, it's a once-a-week dosing, and two, that it is cheaper. The cons of it would be using needles for those who have a fear of needles, and because of the weekly nature of the dosing, people tend to feel the symptoms of low testosterone like fatigue and low energy towards the end of the week. The gel, which is applied directly onto the skin, is more expensive and does have to be applied every day, but it avoids needles and maintains a more stable level of the hormone. Remember that you have to tell your patients to cover where they apply the gel because it can transfer to humans or pets that they come in contact with if they don't. For feminizing, we use estrogen, which comes in a pill, patch, gel, and injection. The pill and the patch are the most often used. Pills can be taken orally or sublingually. The oral is the more common route because the sublingual route has to be dosed multiple times a day and it's inconvenient for people. The patches can be applied roughly every 3.5 days or twice a week. They're more convenient to avoid daily medications, but they can also cause some skin irritation and some of them don't stick as well as the others. Along with estrogen, we use mineralocorticoid receptor antagonists or testosterone blockers in combination. T blockers can help suppress testosterone and create a more estrogenic state, and in order to improve the effects of estrogen. Spironolactone is the agent of choice here. You might hear of cyproterone, though that's not very commonly used in Canada. Aside from estrogen, progesterone is also sometimes used, but it is quite infrequently used as there's not much research on its benefits in feminization or the potential risks that it can have. For monitoring, we usually allow around 4 to 6 weeks of the same dose of the hormone, though some people prefer to go slower, which is fine. There is no one right dose, but rather depends on what changes each patient desires. Though if you're getting close to the max dose of the hormone in a particular route of administration, it might be time to consider a different route of entry. Because as we increase the dosage, the risks and side effects become more prevalent without us getting much of the desired effects. Or it can be possible that your patient doesn't absorb that particular hormone in the particular way that it's being administered. We monitor hormones while titrating, usually around every 4 weeks. And for monitoring the hormone levels for testosterone, we aim that to be in the male range for those who are on testosterone, simultaneously having a suppressed estrogen. For those on estrogen, the estradiol that we monitor is not a great marker for the physical changes that you would get. So people on the same dose can have vastly different estradiol levels. So we don't use it as much to guide our clinical management, and we normally follow physical changes. And additionally, we regularly monitor CBC, liver enzymes, hormones, and lipids for people on estrogen and testosterone both. I hope this was a good introduction to initiating hormone therapy. This is in no way an exhaustive approach, but rather meant to provide an overall understanding. Please check out the resources I linked in the show notes, and particularly the Primary Care Toolkit, because it is really good and takes you through every step by step. Enjoy the episode. Okay, everyone, welcome back. We are on our second part of this multi-part series on gender-affirming care. I have Dr. Nicole Thompson with me, as well as Lucas Wilson and Ray Paxton, who are here to continue our conversation from the last episode. We touched a little bit on what the process of transitioning is, and Ray gave a very great synopsis and kind of the bottom line of what transitioning means. But I want to jump straight into it and talk a little bit about what is the process of getting gender affirming care and what is the process of transitioning in BC. And we have a great privilege to have both people who have the lived experience and who are trans care providers in different sections of the process of transitioning. So I'm really excited to hear. Maybe we'll start with Lucas first.
For sure. So my background is at Transcare BC is in health systems navigation. And so broadly speaking, I can give a bit of an overview, but as Ray mentioned at the end of our last episode, there's so many ways that folks will navigate transition, and so many ways that folks will articulate and decide what they need as part of their transition. It's less of a like linear trajectory and more of a like buffet where people take what they need and then move forward with that, knowing that that's not the same for all people. But really broadly speaking, medically, folks, not all trans folks will access medical transition. When we talk about medical transition, what we usually talk about is hormone therapy and surgery. Sometimes both those things, sometimes one or the other. But when folks are accessing care in BC, if they want hormone therapy, they're needing to connect with a provider who can support them with accessing this. This access looks different from place to place, as well as depending on whether a person has a primary care provider already involved in their care. Some folks will access care through a specialist like an endocrinologist. And sometimes this is a matter of necessity because they're needing endocrine care, though sometimes it's also just because there isn't another provider in the area who can do this for them. Some folks will access through a GP or NP who's able to provide hormone initiation for them as well as assessment. And some folks may access, there are a few sort of trans specialty care clinics that we have throughout the province. So, sort of integrated care clinics where they have a lot of experience providing gender affirming care. Usually it's MPs and GPs and nurses providing this care. So, some folks may access hormones through that path as well. And then when you look at surgery, folks are needing a surgical readiness assessment before they access surgery. The number of assessments depend on the type of surgery a person is seeking, but they'll access that assessment again either through their provider, through provider in their community. Some may access that privately. Folks can be referred to Transcare BC for assessment, especially if they don't have local options or options available to them otherwise. And then their primary care provider will refer them for surgery. For chest surgery, it's to a chest surgeon. There are a number of different chest surgeons throughout the province, but they're all held in a centralized waitlist by Transcare BC. And this is correct as of December 2022, I should say. It might not be the system in a year or two. So I just wanted to preface with like, this is the now. Things can change. And then for lower surgery, for some surgeries, there's the folks will access surgery either in Montreal or at a surgical clinic in BC. There's a surgical gender affirming care lower surgery program. Hysterectomies and orchiectomies as well, so gonadectomies, are direct referrals to surgeons in the province who do those. Which is a pathway that's important to highlight as it's a little bit different than the other ones. And that's sort of the broad overview. Some folks will access a legal transition, so they might change their documents. This can be time consuming and expensive to do. There are some ways to reduce that cost, but it is a barrier for folks, especially if they're a young person. And then folks may access social transitions, so accessing things like a binder or a gaff, things that change a person's body shape to more align with how they feel they want their body to be shaped as or look like, so changing their clothing, haircuts. So when we talk about pathways for transition, we're talking about so many different things, but the medical pathway is broadly what I've described. Folks looking for what the pathway looks like specific for them can contact the Transcare BC Health Navigation team. And what the health navigators do is they will typically ask that person a few questions about where they live, what their age is, all sorts of things, who they're currently connected to, and then build a bit of a plan, or less, well, not so much a plan, but a sort of an options list of what the applicable pathways to care would be for them, because usually it's multiple.
I suppose I can add a little bit just from my perspective as a resident. And again, I'm a surgical resident. I'm not a primary care provider. So my role has not been in the initiation of hormone therapy. But in terms of the literature and in terms of what we teach and talk about with medical practitioners is the concept of informed consent and partnering with your patient, your client, rather than the gatekeeping model, which was used in the past. And so we believe that people know what is best for them and their lives. And that is the guiding principle, I think, of what we should use for medicine. Generally speaking, I really actually think this model of gender affirming care should just apply to people and how we approach everybody in medicine. You know, one of my favorite sayings is when someone tells you who they are, believe them. And so that's as physicians who can prescribe hormone therapy, I think it's actually a really easy process and it's a really easy medicine. And when we look at, I've talked about this before, but the number needed to treat in gender affirming care for a good outcome is one. There is no other treatment in medicine where your number needed to treat is one to have a positive impact, to have a good outcome. And that's actually really, as a healthcare practitioner working in this area, it's actually really exciting to know that what you're going to do is going to result in something wonderful. And so I think approaching our medicine with that in mind, and actually the guidelines are not that difficult to understand. And we'll talk a little bit more, or maybe you can post the resources, but there's like the BC Primary Care Toolkit, and then there's the Sherborne Primary Care Guidelines, literally walk you through step by step what to do and what the monitoring is and how to have conversations with people. And when I think about medicine, I think we do like way harder stuff than this. Like this is very protocolized. This is very easy to do. I think the hang up is in this social perception of gender, and that's where we need to change. So I would encourage every medical student to look at, probably the BC Primary Care Toolkit. I think that it's fairly up to date. It was in 2019. And just say to themselves, like, this actually isn't that much harder than diabetes care. And so I guess that's where I'm rambling a little bit, but that's where I'm going with this, is that the medicine isn't hard.
I really like that you brought up informed consent and believing the patients in what they're speaking about and requesting in their medical and surgical journey. I think it's important to note that there's not one right way to have like a hysterectomy. There's not one right way to be on testosterone. Some people want to achieve certain levels. Some people want just like a lower level of testosterone to appear more androgynous, and all of those things are okay, and none of them is more right than another. And especially with surgical options for top surgery, all surgical options, there, even within those options, there are so many ways to individualize it to make the person feel whole and at one and seen and heard. And I think it's really important to take that time to listen to the patients in their request for care.
And part of that informed consent model is also talking about what, the medical knowledge that we have and what the risks, the benefits, what the alternatives are to care. And then really putting that back to the person who's seeking care and saying, what of these options works for you? How does this help you achieve your hopes and dreams with regards to your transition journey and your gender journey? And then seeing what you can do to provide that. And it's really not as hard, I think, as what we've made it out to be. And it's interesting. I've just, we'll be publishing on this next year, but I put out a survey in Canada to gynecologists and talk to them a little bit about gender affirming care. And it's really interesting because of the responses that I got. Most people believe that every gynecologist should have knowledge in gender affirming care and, should be able to provide a gender affirming hysterectomy. Because really, to be honest, of all the hysterectomies we do, it is the easiest. It is a mostly small uterus in people who have mostly suppressed estrogen. And like it is, you're not going to find a whole pelvis full of endometriosis or massive fibroids. Like, it's one of the easiest possible surgeries you can do. But some of the responses, and I won't say the majority, I say one or two, really believe that this is like a specialty area of medicine, that this is like something only special people who have special training can provide. And I just really wholeheartedly disagree with that. And so I think and we had this conversation, Shadam, when we first chatted about this, is like to break down the barrier of thinking that this is a specialty area of medicine, because it's not. And I really like the idea of like a hub and spoke model. So like the hub, maybe BC Trans Care can be, the hub for maybe like additional training, education, information, complex cases, that kind of a thing. But then the spokes just being people in the community who have, access to information, and then spreading that out and making it more accessible to people. Because the other thing we don't want is that everyone, who is trans or gender diverse, to only be able to access care in one place, because that's a problem. If we centralize all the resources just to Vancouver, what happens to people in Prince George? And so I think, and it's not like I just care about Prince George, I care about everywhere else. That was just what came to my head, but like, or Seychelles, whatever. And so anyways, the medicine isn't that hard. Informed consent isn't that hard. We do this all the time. This is our job.
I think you touched on a really important point. Oh, I'm so sorry.
No, it's okay.
I was just going to mention, just because I read this article literally this morning about this idea of the hub and spokes model. And I read this article about patients who are physically far away from the hub, being rural places like Prince George and Seychelles and the interior. They spend over $1,500 in expenses and travel expenses and accommodation expenses over 2 years, specifically for healthcare. So creating those hubs and relying on those really centers that specialize in trans care, in any type of care really, but since we're talking about trans care, um, distances the people who are in the community who also need that care as much as people who live close to that hub do. And like Dr. Thompson mentioned, creates this kind of air of mystery around something that's just regular care. A hysterectomy is mostly a hysterectomy. I'm not a resident. It's been over a year and a half since I've been in a hysterectomy as a medical student, as a like a hysterectomy operation watching as a medical student. But the principles are very similar in terms of what you do. It doesn't need to be a specialized operation at all. Dr. Thompson, can you talk a little bit about the considerations? And this is kind of just coming from the lecture that you had mentioned, the considerations that you talk about regarding long term care, specifically about birth control, because it's one of the biggest things that you mentioned to me for people who do transition.
Yeah. So for people who are on testosterone, who have a uterus and ovaries, if they are having, insertional intercourse with someone who has sperm with the potential to get them pregnant, testosterone is not a reliable form of contraception. Testosterone is mostly adequate for suppressing ovulation, but doesn't always. And we know now in newer studies that are coming up is that people, and they've looked at hysterectomy specimens for people on testosterone, and actually sometimes the endometrium is proliferative. And so that means that there is estrogen, they're circulating estrogen, and therefore also the possibility of ovulation and the possibility of pregnancy. And so discussing that with people when they come to you with testosterone initiation, just that is a possibility, and that testosterone is also considered a teratogen. So testosterone, if you are pregnant, if you become pregnant while you are on testosterone, that pregnancy will most likely be affected. And so talking to people about options, we know that the oral contraceptive pill is a combined contraceptive pill with estrogen and progesterone, would likely not be an acceptable option for people on testosterone. But again, not making assumptions either, because that may also be acceptable. So presenting all options for people, presenting the progesterone only pill or the Depo-Provera shot or progesterone only IUD insertion can be acceptable options, or talking to people about surgical options. And so your surgical options are your hysterectomy, your bilateral salpingectomy, etc. And so just making sure that people are aware of what their options are, and then also how their hormones will affect their reproduction or fertility in the future, and where they sit on fertility preservation, and whether they want more permanent or long-acting options. And so I think it's just, again, it's a bigger conversation. People know what they want, and if they don't know, if they don't want to make a permanent decision right away, there are good options that are gender affirming and can be provided in a gender affirming way that I think would be acceptable to people.
I think those are great points to bring up. And I'd just like to add that even though progesterone is less of a hormone that would provide or change secondary sex characteristics, there can still be that background hesitancy from trans patients of, oh, this is still a feminine hormone, and how will this affect my appearance and how I feel about myself and my body, and to just give people the reassurance that progesterone only birth control pills or an Nexplanon injection or IUD insertion with progesterone only are safe for those who have a risk of or who have had breast cancer. And if we can give it to those who have are hormonally responsive cancer risk, then it's also safe and will have very minimal to no changes in your secondary sex characteristics as a trans masculine person or a non-binary person.
Thank you.
No problem. Of just how people can feel a bit more comfortable providing care for trans people or where to get more information. So it seems less gatekeepy and less of a main city access only thing. There are so many resources on the TCBC website, but I'm specifically thinking about the clinical mentorship call. Every Thursday, we have different experts in different fields regarding trans care, and you can call in on your lunch hour for free. People can call in. They don't have to participate if they don't want to. They can be learners only, and they can get that just extra little bit of information that they might be looking for.
Can I also, sorry, just while we're talking about this a little bit as well, because I know when I've done lectures in the past for medical students, one of the questions has been pap smears for transmasculine folks and how we can make that experience less traumatic, I should say, and also not making the assumption that it's going to be traumatic for everybody, because that's also incorrect. And so I wonder, Lucas and Ray, from your experience with TCBC, if you wanted to share some tips.
I can take that one on, and Lucas, feel free to jump in if you have anything else. I think it's important to have a good conversation and a rapport with your patient before going into such an invasive procedure. Recognizing that the procedure of the pap test might not happen on that occasion, I think is reasonable, given that we want to really establish that trust and respect and have a good plan for how to go about the procedure. It might not be a big deal for that patient, and if that's okay, then you can go ahead with the test as you would normally do. But if the patient has any reservations, really working them out beforehand kind of allows the person to be a little bit more at ease. And then while working through the test, I think it's important to follow the patient's direction. If the patient wants to stop, they can stop. If the patient wants to keep going, then keep going. If they want to abort the procedure completely, then that's also okay. Just really recognizing that we have to meet the patient where they're at and kind of work at their own speed and pace will not only foster a better relationship for the both of you, but for the patient seeking healthcare in general. And then I would also think that if the patient is seeking maybe other avenues of gynecology care, if we can piggyback it with something else, like if they would like an IUD, but they don't want one for the 3 months because they can't afford it, maybe we can do them both at the same time so they're only having one procedure. Or if they're going in for a self-injectomy and oophorectomy, but they want to keep the uterus, then we can do the PAP test while they're already under anesthesia and they won't have any clinical awareness of the procedure. There's definitely ways around it, and I just think having a good conversation with the patient ahead of time will help that.
I think that's great. And I think I'd also add from a clinician perspective that you need different size speculums. You cannot use what we would call like a Graves speculum on most people, I would say. So you need access to a medium and a small Peterson speculum to be able to provide exams. I would say across the board. I wouldn't just say for transmasculine presenting people, but I think for everybody, I think you need access to different size speculums. And the other question I had, Ray and Lucas, how do you feel about positioning? Because stirrups, and even the word stirrups, I try and use the word foot supports, can also be like provoking of dysphoria. And so what I've done in the past too is just put flat feet. I haven't pulled out the stirrups and just put the bottom sort of part of the bed away, and then just maybe put like a pillow or a flannel blanket, or even sometimes I've used like an upside down one of the little bedpans just to provide some extra support. How do you, like, again, conversation with the patient, but like stirrups, foot supports, how is that seen?
I hate the word stirrups just about as much as I hate the word moist.
Totally.
I think that there's so many different ways to go about it. I like to use like leg supports, leg rests, foot supports, just like you're saying. But to let the patient position themselves, let them just be who they are. If they really don't want to go into the lithotomy position with the leg supports, like you said, putting their feet on the table, I think is fine. There's also like they can be sidelined with a couple pillows between their legs. It might be a little bit more inconvenient of a position for the provider, but it's such a short process. I think the onus should be on really making sure that the patient is comfortable. But I agree, just a little bit of language changing, and maybe even like humor, like just make fun of the leg supports. I think like read the patient, but there's definitely different ways that you can go about it.
Yeah, I agree. And just the noise they make when they come out of the bed, like I've never done it quietly. It always bangs around and I'm like, oh God, I'm so awkward.
And they're so like they just like wiggle it. They're just not like a sturdy thing. They don't instill any confidence in anybody.
None, no. And I've been in some clinics where they put oven mitts on them to make them warmer. And I don't know if it makes them more or less friendly because it also just looks odd. Okay. Anyways, this is very helpful.
And it's interesting. I think we can't forget too that like for some, and I think we've mentioned this, but just wanted to instill again that like really being in dialogue with the client around what they want, because for some clients it might actually be really affirming, like thinking of like a post like vaginoplasty person who might like
Yes.
really want that experience and like might really like love the words. Like I also find the word stirrup a bit strange, but I mean, people have different relationships with that. So I think that like some exams and I think this is coming like straight from some of the resources on our website, and I'm recounting what I've read, but like and I know though that some exams can be really affirming, like they can be gendered exams, and they can be affirming because they are gendered, because that person has not had that experience of accessing that gendered exam before. So it's so across the board, right? Like I think that like wanting to or striving to make things ungendered in some situations where the genderedness of the exam might not be comfortable for the person, but then also in some situations you might really want to relish how gendered that exam is and how affirming that exam is for that person's felt gender. So yeah, so
I'm
very
loving
well.
the language right now. Like relish in the gendered exam. Um, yeah, I think that's fantastic. Can we also talk about one more word? Sorry, just from medical students. And can we just banish the word penetrative sex from our language? And can we use insertional intercourse and just, I was talking to one patient and they were like, penetrative makes me feel like a gunshot wound, like, or a stab wound. They're like, you penetrate somebody with you know, like a weapon. They're like, this is not, that doesn't condone sort of, consent driven, pleasurable activities. And so I think, yes, I'm going to banish stirrups. I'm not going to use that anymore. Moist, I probably will still use, but I think if we can like not use penetrative, that would be like a real goal of this podcast.
Yeah, I think
I
for
think
sure we've definitely moved. Language is fluid, especially um, in regards to gender. Like we're learning so much every day from everybody, and I do think that we are definitely moving a language into more of like receptive and insertional. But if somebody comes in to the office or the clinic or the hospital and says, I have penetrative sex, then I'm going to use what they use because that's the language that they've brought to the conversation. But I think for sure, as a whole, to be cautious, I think receptive is totally it's gentler and it feels more welcoming, pun
Yes.
intended.
That's amazing.
I think you guys touched upon a really important topic in gender affirming care is our language, actually. I remember I was on some outpatient clinic and I was explaining the concept of screening tests in general. And I brought up pap smear and I said, normally people with cervixes will get pap smears every 3 years after initiation of sexual activity. And this patient asked me, why did you use that term? Don't you just mean woman? And I think that was really helpful to have not only myself, but also the staff kind of jump in and say, actually, the medically accurate term would be people with cervixes, because some women don't have cervixes and some people who have cervixes aren't women. So can you share some of the languages that you guys use in a day-to-day basis that are more inclusive of gender and of, or I guess kind of distinguish between anatomical parts in a body and someone's expressed gender, so that some of our listeners can get a better idea of what is the appropriate language to use where?
Definitely want the clinicians here, to Ray and Nicole, to take the lead on this one, but I'll just quickly plug at the beginning of this that on the Transcare BC website, we have 3 resources aimed at providing alternatives for typically gendered language. So one is a clinical resource, one is a general, and then there's a third that I think is relational. There might just be 2. Sorry, I'm forgetting, but there's certainly a clinical and a more general one. So they'd be alternate instead of saying breast or chest, we can say upper body if we don't know sort of what sort of language that person wants, and we want to use a more neutral term. Same with like instead of saying like you wife or husband, we'll say partner. Examples like that. So that's all I'll say on this one, and would love to hear what Ray and Nicole have to say.
I just want to go back to PAP test really quickly and highlight 2 important things. Is that oftentimes people, if a trans masculine non-binary person is on testosterone, they often have less secretions internally and have some vaginal atrophy. So the use of lots of lube, I think, is essential to make it more comfortable for the person. And the test results can also be altered with the use of testosterone and hormone therapy. So to really highlight on when labeling the test, that this is a male person or a masculine person, non-binary person, like really label what that gender is and what hormone therapy they're using, so the lab doesn't reject these tests and potentially throw it away and you have to do a second test for the same procedure. I think that I just want to highlight that before we move on. But just as Lucas was saying, we do have so many great resources on language on our TCB's website that maybe we can give you, Shadan, to post. But I think just figure out what the patient's comfortable with their language. If they bring up a term, then continue to use that term. I like to use language like your internal genitals to speak about like a uterus, not urethra, ovaries, fallopian tubes, vagina, that kind of thing. External genitals for both different kinds of sex organs. And I just kind of wait for the person to guide me to something more in depth. There are some situations where we have to use very specific language, for instance, when signing consent forms. And I like to preface that this might be triggering. We can talk about this later, but for safety and for everybody's awareness, we have to use specific terms on specific forms, and we'll just say it this once, and then we'll go back to using the terms that you identify with.
And I think, from what Ray is saying is taking your guidance from the patient. If we use a word that, or we wouldn't normally use a word, but the patient uses that word, I think it's okay to reflect that back. And I think in gynecology, just really focusing on, not using words like maternity care, and using word like pregnant person instead of pregnant woman, and really focusing on what's inclusive for everybody. And so there's a good list of terms that we can go through. There's several papers and stuff that have been published, but if you just think about like, would you want to be asked if you had a partner? That I do. That's what I use. That's my language now, is partner. And anyways, we could talk about language for a while, and it is in flux. And I think just being open to learning and trying new words, and being corrected.
I want to share, just letting you guys know, in our anatomy courses, we have moved away from like male organs and female organs to just kind of describing what they are. And my work with, I do a lot of research with the Department of Midwifery, and my supervisor is actually the director of midwifery, and we've changed all of our language in all of our manuscripts to refer to pregnant people. Just refer to them as pregnant people and not pregnant women, unless we're citing a paper where they had used pregnant women, because we're not sure what actually was included in there, like what population was included in their paper. But there is that kind of transition towards using more gender inclusive language. And even, my supervisor was actually championing it. And it's really good to see that someone at a higher level, who is the director of midwifery, is focusing on changes that in such a gendered profession, I guess, and such a gendered role. Pregnancy is so like specific to maternity and women and things like that. So I think seeing that transition has been really rewarding for me, and I'm really happy to be moving towards that. So I thought I would share, so we can celebrate our wins.
Yeah, and midwifery's the bomb. Like midwifery really is, leading a lot of the equity work within pregnancy care. So kudos to our midwifery colleagues, and thank you for leading the way on that.
Absolutely. And there's so much to be said in the pregnant person sphere. And I think that one that is really important is to discuss chest feeding, and that it's not just for the pregnant person, that there can be other options, that the non-pregnant partner or partners can induce lactation. There is community feeding. There's so many more options. And I think just being open to asking those questions to your patients, so that they can kind of get a sense of confidence in you, that like you can provide that gender affirming care in so many different capacities, I think is really important. And then just some other words to describe like different body parts, like it's just so specific or for everybody. Like there's this one trans woman that I've seen come through for various surgeries, and she prefers to use the words outie and innie for her transition for genital surgery. She's like, I currently have an outie and I can't wait to have an innie. And for her, that's so affirming. And so that's what we use every time. And some people like to use the words front hole or bonus hole. Like people like to have fun with it. And I just think it's so important to just reflect what we hear from patients.
Absolutely. And I think with, I'll just add that in my teaching, I find that folks can sometimes get really, really worried and trepidation around language, like that language can sometimes be a barrier to even engaging in conversations with patients or with each other around topics related to gender. And I think the interesting thing about language, which we touched on, is that it's in flux, that it's fluid, and that language is ultimately a really imperfect tool. I'm an English major, so this is my only time I get to talk about this in a relevant way these days. But language just gives us a really surface idea of what we're talking. It allows us to exchange sort of a vague semblance of the same idea. So like if we're talking about the color green, I can say green, we can all quickly on the same page. Okay, we're talking about something in the category of green, but you won't know what shade of green I'm talking about unless I show you or unless I describe it to you. So I think language is very much the same way, right? Like we use this language really imperfectly, but to really understand sort of who a person is, what they need, what they're using, we have to dig a bit deeper. And so we can use these broader non-gendered terms to allow us to have language and to talk about things until or unless we have a greater understanding of what words to use in a particular situation or about a particular in dialogue with a particular person, etc. So I would say like I think language is important. Also, like don't let language be the barrier to connecting with and learning about gender. Because you won't know it all.
Yeah. And I think that's I love this. So when we were implementing our curriculum in Calgary, we did focus groups with both the medical students who took the curriculum and then the instructors and then the trans community members that also facilitated it. And one of the big themes that came out of the medical student focus groups is that they were afraid to practice language. They were afraid to screw up. And that anxiety made them perform worse or made them less willing to engage in the trans community because they were so afraid. And it's so interesting to me to think that like medical students actually have the power and the privilege in that scenario. But they didn't see themselves as having power and privilege. They saw themselves as someone who felt very vulnerable in making a mistake. And so a lot of the work that I do in teaching medical students is trying to create safe spaces for language practice. And so do you, Ray and Lucas, have any suggestions for how to engage and how to get over that anxiety of making a well-intentioned, I would say, mistake?
I think one example is the use of they, them, their pronouns. So they're personal pronouns that some people use for themselves, and they can also be handy in that they're non-gendered pronouns. So they're a gender neutral pronoun we can use in place of somebody's name, especially if we don't yet know what pronouns they use. And I think that can really get people sort of feeling a bit like uptight or worried about like, oh, how do I use that in a sentence? I'm not familiar with that. And I mean, practice is one way to do that, but also I think paying attention to how folks are already using those pronouns, because I think you'd be hard pressed to find a person who doesn't use a singular they in their daily life. Same with a person who doesn't already use a non-gendered language and referring to like partners or like parts of their body when they don't know the specifics of it. So I think just getting people familiar with like practice, but also like pay attention to like how these words are already coming up in your daily usage of them. Because I think when we focus on using words, that's just like when we're focused on anything, that's when we can really like fumble and really start to worry. But I think when you relax and actually, oh no, I referred to the post person as using they them pronouns the other day because I had no idea who they were. I never met them, and they quickly dropped off a parcel and left. So like I used they several times there. I didn't even think about it because it just comes so naturally. So I think that's one way. Ray, I'd be really interested to hear what you have to say on this one.
I think you both summarized it up nicely, and it's just practice. And maybe it's you and another medical student going out for coffee and trying to be mindful of using they them pronouns when you're just observing different things around your surroundings. Finding creative ways to incorporate it in non-work environments so it just becomes more natural in your work environments. I just think it's about exposure and practice that both Nicole and Lucas have suggested.
And if
Thank you.
mistakes happen, I'll just add, because another question was about mistakes. I think it's not so much about like avoiding, like I think mistakes are natural. We all make mistakes. And mistakes are part of learning. And when mistakes happen, we do have a resource on our website that I'll plug again called Making Mistakes. And the shorthand of it is that you follow, it's a bit of, in my mind, it's a bit of like a sort of silly 3-step process. I say, oops, ouch, move on. On our website, the version there is, I think, a little bit more eloquent than that. But oops being like acknowledging when you make a mistake. Don't just say like, I never make mistakes. What are you talking about? Like acknowledge, oops, I made a mistake. And then ouch, acknowledging how that could have impacted the situation, that person, caused harm, even though you didn't mean to, right? Like things can still happen, harm can be caused, and then move on, which is the important part of like not drawing attention to it. It's not your Oscar moment to like have your big speech about like how sorry you are. It's a moment of trying to minimize harm. You so acknowledge and then you minimize by correcting yourself and then moving on. So if I'm referring to somebody, I use the wrong pronoun. She, I mean he. She, I mean they. Right, and then we're moving on. So just knowing how to navigate mistakes and also being authentic and using those as learning opportunities to say like I messed up and actually that wasn't like I didn't want that to happen, but how is that going to help me then next time do better? It will.
Yeah. A really good friend of mine is a trans educator, and he has this like hilarious speech that he gives people. He's like, if you mess up someone's pronoun or something, he says, it's kind of like running over a gopher while you're driving on the highway. Like you see it in the rear view mirror and you're like, oh God, shoot, I feel really bad about that. Sorry. And then you keep driving. You don't pull over. You don't try and resuscitate the gopher. You don't drive back and profusely apologize to it. You still feel bad about it because it's not a cool thing to have happen, but you keep driving, you keep moving forward, and you feel bad, but you move on. And so it's that same sort of, I love how he teaches because he also like brings in lots of humor to things. And I feel like people really identify with that. And I've shared that with some people and they're like, okay, yeah, like, oops, ouch, move on.
Thank you for touching on that, because that was exactly what I wanted to ask. I think even when you do practice, mistakes are bound to happen. And again, they're well-intentioned mistakes, but having that script of what to do when a mistake does happen and not making a big show of it. This happened to me actually in believe it or not, in an equity and diversion conference that we were doing. I accidentally misgendered one of our panelists, just said, oh, exactly like what you said, Lucas. I said she, I mean they, moved on, and it was all okay. But I did feel bad, and I think I understand the compulsion to want to be like, oh my God, I'm so sorry, I didn't mean this, and kind of draw more attention to it. But I had to really fight that, and it received good feedback. So I've really learned to be like, okay, moving on. And I want to be mindful of the time because I know everyone has things to do. So I want to close this off. So in our medical school lectures, we always ask our lecturer, the guest expert, whoever is giving us the lecture, to share some pearls or takeaways from the past 2 hours that we've talked about. And we honestly probably could go on talking more, but maybe I'll start with Lucas, if you want to share some takeaways for our medical trainees.
I think that what I'll share is that the takeaway I'd pass along would be that people should be treated according to their self-identified gender, right? Like the individual is the expert in their own experience. And I think if we really listen to that individual, we will provide gender-affirming care, because gender-affirming care is essentially just care that respects and follows the wishes of that individual. So if you take the time to ask and you listen, you are already providing gender-affirming care.
Ray, do you want to share some takeaways?
Yeah, I think it's important to recognize that it's okay not to have all the answers in the moment, but to ensure that you do follow up on the research promise, or that the referral that you said you would send by the next appointment or the next encounter, to help achieve like a full and sustaining therapeutic relationship with your patients, your fellow coworkers, with the person at the grocery store, really with anybody. But it's okay not to be an expert today or tomorrow, but to just use that moment to reflect on it and grow and move forward.
Do you want me to go next? Yeah, I guess I'm the last one. I guess mine would be that, if you're a practitioner and, and you are interested in this area, as I said before, hormone therapy is not hard. We do way harder things, and we need more people to provide this care. So if you're interested, there's a ton of resources out there, and there is no certification process. You do not need to be certified to do this. You are a physician who is responsible for your own practice. And as part of that, if you feel like you're able to provide this care, which is very easy, then you can do that using an informed consent partnership model with your patient. And then I guess the other thing, it sort of mirrors what Lucas was saying a little bit, but that gender affirming care and treating people as the person that they present to you and tell you that they are is actually just a model for every kind of care we should provide in healthcare. When anyone presents to us, we should try and find out a little bit about who this person is and mirror their language back to them and treat their care with love and concern, and with the concept of like, how does this care that I'm providing help this person live a better life? And I think that's gender affirming care. I think that's diabetes care. I think that's like contraceptive care, everything that, pregnancy care, everything that we do really in healthcare is to help the person get out of a healthcare setting and live the life that they want to lead. And so just to take that gender affirming care model and it's just care.
I love that. I mean, if gender and affirming care has a number needed to treat of 1, and if we apply to everything else, then everything has a number needed to treat of 1, and you make lives better, even if it's not necessarily within the gender affirming care space. I want to thank you guys so much for coming on. I really, really appreciate all of your stories and teachings. It's been so wonderful to learn from every single one of you. Thank you for being here. And like I said, for the listeners, all of the resources mentioned and any resources that they send to me after the podcast is done, I will share in the show notes, and you guys can read those and learn from those further. Thank you guys again.
Thank you. You did such a good job.
Thank you so much.
Thank you.
Thanks for tuning in to Just Medicine.